Good morning. I'm Jessica Lovell. We are live from the Dolph C. Simons Jr. Family Broadcast Studio at our Olathe campus. Welcome to the Morning Medical Update World Cup Health Coverage. The University of Kansas Health System is the official medical services provider for the Kansas City World Cup 2026 host city, and we have a stacked show for you this morning. Today we are talking about hydration, from being dehydrated to overhydrated. We'll also update something public health officials are watching pretty closely, and that is wastewater. We have a full panel of experts joining us. Welcome back to Dr. Dennis Allen, Venue Medical Director and Emergency Medicine Specialist. We have Dr. John Anderson, Director of Informatic and Molecular Epidemiology for the Kansas Department of Health and Environment. We have cardiologist Dr. Shannon Hoos-Thompson joining us, along with medical oncologist Dr. Gary Doolittle. And of course, we have Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control here at the health system. Well, in this heat, there are health risks, as we know, associated with dehydration and spending prolonged periods of time in crowded areas. The National Weather Service shows 79 degrees Fahrenheit today, which is 26 degrees Celsius. Humidity of 93. Next week, though, the heat index is going to be high at about 110. So look out for that. I want to welcome back Dr. Dennis Allen. You're like part doctor, part co-host.
I know.
I like it. I like having you with us on this Friday. So what kind of potential dangers are first aid stations focused on recognizing from people out there?
Yeah, I think for the crowds, we're looking for any alteration in their mental status. And then we'll start checking their temps. Most of the time, they just need to get out of the sun. They just need to get out of the heat. They need to hydrate. Sometimes we'll do it with water. Sometimes we'll do it with more of a sports drink, something that has some salt and electrolytes in it.
Well, and we've been noticing that these temperatures feel cooler. Have we seen heat-related health issues come into those first aid stations inside and outside the stadium?
Sure, yeah, we have, and it's just been exactly the number we would have predicted. And we've used our just our cooling station has prevented a lot of people from having to come to our medical care. That's a more advanced care.
Any of those cases, have they turned into emergency department visits? Have they escalated to that point that you know of?
No, they really haven't. It's been a very I know a lot of people that are going to games are from Kansas City, but it looks like it's a very experienced, well-traveled crowd.
Okay, good way to say that. You were there last night. We're going to talk about that here in just a moment, but I first want to show a photo from a training that we do here at the health system. What are we seeing in this photo?
Well, I'm just looking to see if I can see it very well there.
Looks like a very cold ice bath.
Oh, there you go. Okay, all right. Just didn't see that picture very well. Yeah, that's a cold immersion tub.
When would someone need this type of care?
That's heat stroke. So their temperature will be, they'll have alteration in mental status. Their temperature will be generally above 104, 105 degrees. And the best thing to do is, and we've got these set up to use in first aid. We have them set up to use for the players. Down in the Player Medical Center, and it's just basically an ice bath.
No need to use them so far, though, right?
Nope.
That's good news.
And you go down in it, and we keep you in it until your temperature is 102, and then actually you'll do very well.
So we tell people to start hydrating before. Hydrate early, as they say, before you go out and attend a big event like the World Cup. Is it possible to drink too much water?
You know, I think if in most people, the answer is no.
Yeah.
Because their kidneys are probably, going to handle almost whatever. I think when the thing you have to watch out for, particularly with the exertion, is you're not just losing free water. You're losing electrolytes as well. So when you can overhydrate when you exert with just free water and actually change some of your electrolytes. in your bloodstream. But in general, that's a lot of exertion, and the kidneys usually handle almost whatever you throw at it.
You were at the match last night.
I was.
Tell us about it.
Oh, it was fun. They were totally uninterested in the fact it was raining.
I was saying, they are not listening to my weather report.
They're listening, they just don't care. They're going to go anyway.
They're going anyway.
And they stayed. Nobody left. It just poured on us.
Because you were down on the pitch.
Yeah.
And you just doused in the rain.
Oh, it just poured.
That sounds kind of fun, though.
It was fun. But you know, we've done this in the rain before when it was 35 degrees. So this was a lot. This was a lot. This was actually nothing. It was fun.
Well, thanks for being here with us this morning. After hanging out down there, I'm sure you're having so much fun. So
no problem.
You're going to stick around for some community questions.
Sure.
And send those questions in now. If you have them, use the chat on YouTube and Facebook. You can let us know if you are a reporter by sharing the media outlet that you are with. Well, we want to turn now to John Anderson. Dr. Anderson, first off, I have to ask you, what does a molecular epidemiologist do?
That's a great question, because it is an emerging field that we've been able to build up more since the cost of doing molecular science has gone down. And I think you're probably familiar with it. Think of a crime show where investigators trace DNA between crime scenes. We do the same thing, except the criminals are viruses, bacteria, and fungi that make people sick. And these germs leave genetic traces everywhere they go. So we can connect the dots and figure out how they're spreading. Maybe it's onions on a hamburger. Maybe it's a piece of medical equipment that's malfunctioning. Once we know the route, we can fix it. And that's a very focused, suspect level, in this analogy, part of my job. I also have another half of my job, which we're going to talk about today, and that's tracking germs at a community level, almost like watching a whole criminal network instead of one suspect. And we do that through wastewater. Essentially, after someone's body fights off a germ, traces that end up in the toilet, and then it goes to the treatment plant, and we test that wastewater that comes from the treatment plant to get a picture of what's circulating across an entire community.
I love the CSI description. That totally makes sense. So, John, talk to us about when hundreds of people travel to a huge event like the World Cup, what is the health department closely watching, and how are you monitoring those things specifically?
Absolutely. So we're watching a few things. Infectious disease risk, of course, from so many travelers in one place. These are people who aren't from Kansas. They might be bringing in pathogens that we're not familiar with. And so it's very important to keep a good tab on that. And then, like you've just talked about, we've got environmental risks like heat and storms. And then we also have things like assault and drug use spikes that come with big events. And so we pull that picture together from a few sources: weather forecasts, wastewater testing, anonymized hospital and emergency department data, and also reports from citizens and physicians telling us what they're seeing on the ground. And we put that all together, and that tells us what risks Kansans are facing in real time. Thankfully, the World Cup hasn't produced any exceptional risks to Kansans so far, and it's nice to know that we'd catch it early if that changed.
So no risk so far, and you just mentioned how testing wastewater determines what is circulating in the community. But at what point, John, do you worry?
And so when we start to worry, we get concerned when pathogens that are common start to climb to moderate or high levels. Think influenza A, influenza B. We expect influenza A and B during the flu season, but if it starts getting really high, that's concerning. We of course work with our partners to make sure that they understand the risks, and also talk to the public and share that risk with them so they can manage it. And then there's another side of what that I mentioned before, that these rare pathogens that we're not used to in Kansas. This might be something like Mpox, where one detection in the wastewater might be a fluke. It happens, but multiple detections in a row tells us something is real. And then we alert providers so that they can include that in the symptoms and conditions that they're looking at, and we also tell the public what to watch out for.
So what are the main viruses and bacteria that KDHE is currently monitoring?
Sure. So on the respiratory side, we track the usual suspects: influenza A, influenza B, RSV, the virus that causes COVID-19. And that data is actually public on our website. We have a nice wastewater dashboard. And then for the World Cup, we specifically expanded to additional pathogens because of the number of people that would be coming in. We're working on a dashboard for it. Right now, it goes out to our partners. And we're watching vaccine-preventable diseases like hepatitis A and measles, stomach bugs like norovirus, mosquito-borne threats like West Nile virus, and even an emerging fungal pathogen called Candidamycin auris.
Dr. John Anderson, great information this morning. We really appreciate you joining us.
Thank you.
Dr. Gary Doolittle is with us. How are you?
Doing great, Jessica. How about you?
I'm good. We found a way to get our favorite medical oncologist to join us for our World Cup special. So glad you are with us because we're going to talk about the heat and the UV levels. Can you explain the heat risk associated when we have high UV rays?
Yeah, I think there's a reason you invited me this morning, Jessica, and it's all about the sun exposure that, you know, someone that's going to the games will undoubtedly be dealing with. And, you know, UV radiation is what causes skin cancer, and there are ways to quantitate how much UV radiation we're exposed to. There's actually, it's a UV index, and you can Google it every day to figure out what the sun UV index, the exposure really is. Some days, bright, sunny, hot, the UV index is going to be really high. And then on days maybe like today, the UV index will be lower. So you can, honestly, you can kind of gauge what your risk is when you go out. My challenge with it when we discuss this is that if you're outside and you're in the sun, you need to be protected, whether the UV index is low or whether it's high. It's just giving us an idea of what the risk is during certain times of the day.
So when those levels, Dr. Doolittle, are high, like a 9 out of 12, how can we protect ourselves properly?
Yeah, good question. It's really, it's like, do you want to miss a game? Do you want to not go to the lake? The answer is no. You want to live your life normally. All we have to do is sun protection, right? So sun protective clothing, rash guards are great. They have an SPF of 55. Hats, sunblock, sunscreen. Just making sure that you're protected when you're out in the sun, but go out and enjoy yourself, enjoy the game. Even if it's pouring on you, Dr. Allen, enjoy the game.
Yeah, he loved that. Good cool down system. So, Dr. Doolittle, you and I have talked about this because we have that fair skin and the blue eyes, and we know that we really cannot go without any type of sun protection, but it's cloudy out, so sometimes you can forget to do that. What kind of real exposure, though, can we still be getting on cloudy days? Just give us that reminder.
Yeah, that's such a good point, and it is harder to remember. When you're out in the sun and it's hot, you know, you're thinking sunblock and sun protection, but when you go out and it's cool, you just don't have that same trigger or that internal voice telling us to protect. But the reality is the UV index is still high enough that you're getting UV exposure, and that exposure is putting you at risk for skin cancers. So even on a cloudy day, you need a block.
And of all
protect yourself.
Yeah, and of all the skin cancers, we know melanoma is the most concerning. What are the early warning signs of melanoma?
Always trying to get the word out about melanoma and skin cancer screening. We talk about the A, B, C, D, E's of melanoma. If you notice a mole that is changing, if it is itchy, if it's bleeding, if it's new, anything that is of concern like that to you, point it out to your provider, because you can't be too careful with something like melanoma. But honestly, the greater number of skin cancers include basal cells and squamous cells. So there's melanoma is the most deadly of all the skin cancers, so we worry about that. But what I'm really thinking in terms of is just general protection against skin cancer as well.
And what would you say is the one symptom that maybe people tend to ignore, that maybe is kind of easy to dismiss?
I think a lot of times, particularly like for melanoma, they've had a mole for years. They remember it as a child, and it starts to change. And I think that may be the situation where you think, I've had this my whole life, this can't be a real problem, when in fact, half of the melanomas that we diagnose evolve from a pre-existing mole. So that scenario in particular, I always feel for the patient, because they know they've lived with it their whole life, and yet it has now evolved into something that's much more serious.
Last question, are there any certain areas on the body where skin cancers are commonly missed?
Yeah, I think there's 2 points to that, really. I mean, we can't examine our own back, right? And we can't examine the backs of our legs, and that's the most common site for men and women, respectively. So I think the more important point is to get in and get checked by your provider on an annual basis. And if you do notice something, point it out. The other thing is, I can't tell you the number of spouses that have saved their spouse's life by noticing a mole that the patient can't see himself or herself. So even asking family members to check, being vigilant, just thinking that way. And during your annual visit with your provider, ask for a skin check, right? Because that tends to be the thing that falls to the bottom of the list sometimes when we have more acute problems. But prevention is really key, and early detection really key in terms of controlling this disease.
Dr. Doolittle, always great advice from you. Thank you so much, and stick around because I'm pretty sure we'll have some questions for you from the community.
I will.
Okay, Dr. Hawkinson, good morning.
Hi, how's it going?
It's good. Lots of excitement, lots of fans, people coming from everywhere to watch these matches. Have you been staying up on it?
Oh, for sure. Yeah, absolutely.
You're our soccer doc, the soccer doc. Okay, so let's dive into this. We just heard that KDHE is monitoring what they're monitoring in terms of wastewater. Is there anything that's concerning you at this point?
Yeah, you know, it's interesting. John Anderson and I, we actually were talking about monitoring and doing things and coordinating things more than a year ago, so preparing for this. So I'm glad he's on and talking about that. Right now, from what I can see on the public-facing information, no real concerning things. Obviously, we're always looking for things like GI pathogens, norovirus, rotavirus, things of that nature. And then you heard him explain some of the other things that we're looking at, but really nothing concerning at this point. I know we've talked about respiratory viruses. Again, respiratory viruses are quite low right now. We are not in the respiratory viral season, so no concerns about that, but we know there always is a low level of circulation in the community for those. Obviously, measles is always a concern now with the situation that we are in our local communities and in our country in general. No detections that I've seen for measles, but you also have to understand that there are exposures happening every day in different places, public places especially. But if you are vaccinated, you really don't have concerns about that at this point. So in general, wastewater testing looks good. No significant concerns right now.
That is good news.
Yeah.
In terms of, this is very basic, in terms of basic principles of preventing infectious diseases and illnesses, how effective is something simple like carrying around hand sanitizer at a big event like the World Cup?
Yeah, I think it's extremely effective. If you combine the hand sanitizer with really trying to keep your hands from touching your eyes, your nose, your face, you are going to probably decrease your risk of a lot of infections, common cough and cold viruses, but also GI viruses by over 90%. Now, we know the caveat is that norovirus is not really affected by the alcohol hand sanitizer, so it is important also if you can intermittently perform good hand hygiene with soap and water. But overall, yes, using good, adequate hand hygiene with alcohol hand sanitizer when you're out in the community, trying to avoid touching your hands to your face, especially when you're touching those high-touch surfaces out in public, you're going to reduce your risk of infection greatly. So I think that it is a good strategy to use, and it can protect you.
Great reminder. Hawk, thanks so much for being with us. We'll see you back here Monday morning.
Thank you.
Well, heat and the heart don't always mix. Dr. Shannon Hoos-Thompson is with us. How are you this morning?
Hi, Jessica. I'm doing well.
Good to have you. So, Doc, how does the heat and dehydration affect the heart?
So it's like every other organ in the body. It becomes overworked and stressed, and therefore, the nice thing about the heart is it lets us know a lot sooner or a lot more obvious than some of the other organs in our body, where you can feel it. The heart takes off, it's pounding, it's racing, it's letting you know that it's struggling and you need to help it out.
Well, there's a lot of fast beating hearts out there at watching these games. Can dehydration cause things like chest pain and palpitations that could be missed?
No, absolutely. I think as a community as a whole, so far this summer, we've been very fortunate with our weather. But as we see that heat start to climb, especially with the humidity that we're going to have after the rain and things like that, your body has a hard time cooling or regulating that. And the heart recognizes that, and the circulatory system and our ability to maintain proper circulation and changes, and bottom line is it's good to use a friend. Like, sometimes people notice when you're struggling before you admit it for yourself. So as we see people showing up in groups, and you see somebody sitting next to you at a game or at some sort of event, and you can tell they're having some trouble, inquire, let them take a moment for themselves and find out if they're doing okay.
Yeah, look out for each other. Who is most vulnerable to dehydration-related heart issues?
I would tell you it's the very young. So infants probably under the age of 1, and then the elderly or people on cardiovascular medication. So if you are taking medications for high blood pressure, diabetes, your body's has an altered functional status to begin with, and sometimes those medications can kind of mute your recognition or your ability to adapt. And so if you do take medications, especially for cardiovascular health, you are going to be more vulnerable.
Those hydration powders that you see that you can add to water, could those make a difference? And also those drinks that you add the electrolytes?
Yeah, I give the advice a lot that it's more than water. Water's great. You always start with water, you end with water, but using the electrolytes and things like that is important. As far as true supplements that you see advertised or sold, I wouldn't really go that way. It's just your basic things, putting some salt, getting some sugar into your body really does make a difference. The type of foods you eat, so grabbing a banana, an apple, some grapes, rather than the nachos or the fried chicken strips and hamburger, what you eat and the amount you eat. So there's a reason there, the old adage of don't swim for 30 minutes after you eat is real, because you don't want to challenge your body to have to meet circulation demands in different areas, especially when you're hot and active and a little dehydrated. So be aware of what you're eating, what you're drinking, and that can really set you up for better things.
And what would you say would be the one thing that someone should never ignore that could signal a heat-related heart problem?
When you're in the heat, you start to get cold. Chills, actually, because your body actually is letting you know that it can't sweat, or it's kind of starting to shut down. And honestly, once you've hit that point, there's a lot of damage. And we talk about the heart because, again, the heart usually is one of the first things you'll notice. So you feel the heart racing, you feel kind of unsteady. And the answer is that just do a check. Just step aside, find some shade, get out of the hustle and bustle, and let somebody know. Again, it's important somebody knows around you. And a lot of times it's not just your sensorium that you need. Somebody else can kind of observe what's going on with you, and that can really make a difference.
Great stuff, Dr. Hoos-Thompson. Thank you so much. We want to get to your questions this morning. Dr. Doolittle, this first one's for you. It's from Jenna, wanting to know, is sitting under an umbrella enough protection from the sun?
So, great question. I think seeking the shade when you're out between 10 and 4 is one of the things that we suggest for sun protection, but I don't think it's enough singularly, right? Because you're not going to be under the umbrella all the time. I think it's great to avoid the sun, and that's one way to do it, but I'd still want to combine that with block, screen, sun protective clothing, a cap, right? It's a great thought, and seeking the shade we encourage.
We just mentioned that, Dr. Allen, you were at the match last night, singing in the rain. How was that? That was fun.
It was.
Great. Okay, but Jill has a question. She wants to know if there is any issues when it comes to like managing medical emergencies when rain is a factor. Is that ever?
No, we really are just going to go out. We're really just going to go out and do what we do. And it really doesn't affect us at all. Same meds, same procedures. We went out and practiced. We do a practice before every match, and we did our practice in the rain just to be sure we were.
What's the practice? What does that look like?
We do simulated players down, and it's kind of interesting because the crowd starts coming in, and they see us over there looking like we're running a cardiac arrest. They all start crowding in to see what's going on.
Sure.
And because we try to make it look as live and we did as we can. We did it in the rain just so that. You just don't want to get yourself distracted by the rain.
And you do that before every match?
Every match.
Dr. Hoos-Thompson, next question's for you. Carson is asking, what does it mean to be low on electrolytes? Like, what does that actually mean, and what issue is that causing inside the body?
Well, again, it just shows the regulation within your body. When you talk about sodium and chloride, when you're dehydrated, the balance of your sodium chloride has a lot to do with the water and the content within your blood and within your cells. We see a lot of potassium swings and shifts, and that's when a lot of cramping and things like that, and that also goes along with magnesium. So what does it mean? It means your body has to keep a balance of all things, from the pH, the acid base, versus the electrolytes, and how things are able to move in and out of your cells. They really are critical aspects of it. So that's why it's more than just water. It is those electrolytes and making sure that they're available to your body and your body can use them effectively.
This has been a great conversation, and we want to thank all of our experts, doctors this morning. Remember, we have you covered at the World Cup, bringing you the very latest updates in our live shows every Monday, Wednesday, and Friday, right here at 8 a.m. You've heard of sore losers, right? But there's also a thing called a sore winner. On Monday, we focus on the stress of winning and losing, so don't miss that. Plus, we put together some quick videos to help with everything from emergency care to staying healthy in the heat, and even some travel tips in there. So today's video is going to help you keep cool in the summer heat, and you can find those on our website. That information is there on your screen. Then stay tuned for an encore edition of the Morning Medical Update. You're going to meet two sisters who share everything, including a breast cancer diagnosis. We explore how genetic testing can help patients and families make more informed decisions about their health. Thank you again for watching, and we're going to see you back here on Monday.
Heat and humidity can make you seriously sick, and unfortunately, Kansas City offers both during the summer. I'm Dr. Brian Bieber, emergency medicine specialist. Do you know the signs of heat illness, also called hyperthermia, and how to survive it? Sweating is one survival tool. It's your body's built-in air conditioning. However, you can lose 1 to 2 liters of sweat per hour in high heat. That's why hydration is key, and it starts the day before. Don't wait until you're thirsty. Keep drinking fluids, and remember, when you're sweating a lot, water alone may not be enough. Electrolytes, like those in sports drinks or packets, can make a big difference. They replace sodium and other minerals lost through sweat, improve fluid absorption, and help maintain blood volume and circulation. Ever wonder why you're flushed when you're hot? That's another survival tool. It's called vasodilation. Your body increases circulation near the skin, allowing heat to escape into the air. Sweating and feeling flushed are 2 symptoms you're getting overheated. Here are other indicators you're heading toward hyperthermia: fatigue, thirst, headache, and dizziness. These symptoms progress into nausea, muscle cramps, and heavy sweating. Severe symptoms include confusion, vomiting, or fainting. Severe symptoms are when hyperthermia becomes a medical emergency, and you should call 911 or head to the nearest hospital. At the first signs of overheating, get out of the heat and into a cool space. Use ice packs or wet towels to help cool the body's core temperature as quickly as possible, and give them water if they're able to drink. One last tip. Remember, hot cars can be deadly. It's called the greenhouse effect. Heat becomes trapped. A car can reach 109 degrees in 20 minutes when it's just 80 degrees outside. If it's 90 degrees, it can top out at 160 degrees. Heat and humidity in the summertime is no joke. Stay cool and stay safe.
Coming up today, it's a shining example of the importance of knowing your family history and being proactive in your health. And it's what two sisters attribute to them being alive today. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. It's the ongoing journey of two sisters who have always been inseparable. Josie and Jordan grew up sharing everything, but they never dreamed they'd wind up sharing the same diagnosis.
We're 15 months apart. We played on every sports team together. We've gone through college together, all the things. So we've always been best friends, so close.
Sisters Josie and Jordan Wooderson so far have done it all together, the good and the bad.
We said after our weddings and after our cancer, we're gonna be like bored. What do we do? You know, just I guess enjoy.
This is why I have my sister. She helps me.
These two are embracing life.
She does everything girly for me. Yeah. Who are those girls?
And taking nothing for granted.
The sky is more blue, the sun shines brighter.
That's because in 2022, Josie, a nurse, felt something was off.
I had noticed a spot in my breast. I had had it checked out, and then about a year and a half went on, and I noticed it changed.
She was referred to the University of Kansas Cancer Center. Test results would later confirm Josie, at just 26, had breast cancer.
Of course, my mom and dad and my sister came straight over. You know, from day one, I was like, okay, we don't have a choice. We have to fight this. We have to go through with it. And you have to go through it to get through it. That was kind of my motto through the whole thing.
Their grandmother also had breast cancer. So amidst doctor's appointments, treatment plans, and chemo, Josie decided to take control of what she could. She met with a genetic counselor at the cancer center.
Found out that I was BRCA1 positive, which then triggered the rest of our family to be tested.
Which of course would include her sister Jordan, who tested positive for the gene. Just a few months later,
We didn't want to believe it, but in the back of my mind, when I saw the abnormal lymph node on the scan, you know, the spots I weren't worried about. A lot of women have benign spots, but when I saw the abnormal lymph node, I was like, that's not,
especially knowing our genetic and the fact that I had already had breast cancer, and we knew the odds, the statistics were not in our favor.
They were right. This would be another thing the sisters would share. Jordan also had breast cancer.
It was
the same as mine.
Malignancy, yeah, invasive ductal carcinoma.
After 6 rounds of chemo and a double mastectomy, Josie is in remission and considered cancer-free.
She's a red bird.
There was one on the fence.
She's also back to work and able to support her sister as she begins chemotherapy, which will then be followed by a double mastectomy.
But they're growing.
Yep.
But first, it will be a walk down the aisle for both.
We love flowers, making bouquets.
Right now, these two are way more interested in talking wedding plans than chemo appointments.
It's almost indescribable, really, our relationship now.
I don't really think there's anything in the world that could come between us at this point.
Not a chance. Well, this morning we are so happy to have Josie and Jordan with us, along with breast surgical oncologist Dr. Kelsey Larson and Dr. Laura Nye, a breast oncologist and medical director of breast cancer prevention, both with the University of Kansas Cancer Center. So glad to have all of you here with us.
Thanks for having us.
So excited. I've been waiting to have you two back here with us and doing well, I take it?
Yes, very.
Jordan, just some really exciting news. Well, lots of exciting news to talk about today. But first, just tell us where you are with your treatments.
I officially finished chemo on October 6th. It was a very exciting day. Dr. Nye got me through it all. And so I'm almost a month out, feeling great. I already feel like I have some energy back and feeling more like myself. Following up this coming Tuesday, Dr. Larson will be performing surgery. And after that, just healing and then radiation to follow. I spoke with radiation oncologist the other day, and then some more treatments, immunotherapy with Dr. Nye. So a lot to go, but a lot behind me too. So feeling really good.
That's a great way to say it.
Yep.
Josie, you've been declared cancer-free.
Yes.
That is the greatest news. What's it like to be back to work as a nurse, right?
Yes. I've worked in labor and delivery for 6 years, and I think it's just always been in me to want to help people, and so I guess being here, I kind of actually feel like I fit in because I kind of understand very different worlds, but there's a lot of similarities just in healthcare in general. So I guess also being a nurse, when Jordan was diagnosed, it was kind of my instinct to just want to help her, probably too much some days.
I bet.
But I wanted to do anything possible to help her and to get through, and I think that's kind of how, our mentality was and what helped us stay positive through it.
That's just what you do as sisters.
That's right. Yep.
Okay, so we got to get to this good stuff off the top. Jordan, when we spoke, you were engaged at the time.
Yep.
You got married just last weekend.
Yes.
What was this big milestone like for you?
It was a very actually relaxing day. I know that people think weddings are stressful, but for us, it was like a day we didn't have to go to chemo or a cancer appointment. So actually it was very relieving to just be with my friends and family and have everyone I love in one room at once. It was pretty meaningful. I think, sometimes people get caught up in, the decor and all of this and everything, but for us, it kind of had a different meaning this year. And I'm pretty thankful to have a husband who knew of my diagnosis and is sticking with me through it all from the beginning. So in sickness and in health was taken very seriously early. So we've started off on a pretty good foot and have
people
a very,
say,
very strong relationship.
We say though, you're tearing up already?
Yeah.
You guys are so sweet and so cute. I mean, I tell you what, these two are just so wonderful patients. And I actually remember when you were diagnosed because you were coming back for follow-up visits.
Yeah.
So I think I heard about it from you and from my team.
Yes.
And so it sort of feels like I'm just saying I'm part of their family because they are just
you are our second
We've said
family.
that. We've said in the last, because it's been almost a year and a half since our whole journey started with you guys, and it does, you truly have become part of our family, and it's like a home away from home, oddly enough.
We don't mind it though, because we know that you're saving our lives.
Yeah.
Are you bringing Kleenex? Yeah, Anthony. Come on in, Anthony. Yep.
When I got my wedding photos back from the photographer, I immediately was sent to every doctor, because every nurse, every doctor knew the wedding's coming up, and they just know, and hers too in April. So it's like they know and care about very personal parts of our lives besides just the cancer.
I think our very first conversation with Dr. Nye was, okay, she's got a wedding in October. How are we going to get her to this?
We had some bumps, but
we did great.
Yeah,
you made it
beautifully.
Well, and Jordan, what I loved about your story, and for both of you, you said a lot of women or people would say, I want to wait till after my treatment. I want to wait till my hair grows back. I want to wait till I have more energy.
Right.
And you said, I don't want to wait.
No, let's do it.
Let's do it.
You never know.
You never
just,
know.
You live differently every day, and to us, we've kept, every chemo, we planned my wedding, and
we knew Jordan and Joe were going to get married before, even before I started, so it would have been April of 24. They weren't even engaged yet. And I found out, and I think the day of or the weekend of, I was like, can you go ahead and get engaged and get married already so that I can be there and make sure that everything's okay?
So again, no big honeymoon because you got this double mastectomy coming up next week.
Yep, next fall we're planning our honeymoon. So we have it planned and we're ready. So hopefully healed up and no problems by then, and we'll be good to go.
So I want to go back a little bit. Josie, when did you first, because this all really started with you, when did you first discover that spot on your breast? You knew something was wrong, but you're a nurse, you knew something was a little off.
Yeah, so I think it was August of 2022, I had noticed a spot, and I was actually on birth control for quite some time and decided that I was going to get off of that, and I noticed it started to change. So then about a year and a half after that, so the spring of 24, I asked my providers again, hey, can we look at this spot again? Is there any way that we can get scans? And they're like, yeah, absolutely. I work alongside them, so we trusted each other in that judgment. And it was pretty large. The surgeon at our local hospital told me, you can remove it, biopsy it, or we can leave it alone. And I don't know, something in my gut just said, let's get it out. They were confident that it was benign, but the way it felt and the size wasn't really matching up with some of the imaging that they had. So they did a needle localization prior to surgery. And they found some additional spots when they did that ultrasound. So I had the images and I had to go back, and part of me knew. I went back in the holding room and my parents were in there, and I could hardly even talk to them because I think I knew in that moment. Everybody had been telling me, it's fine, it's benign. And for some reason I told people, I was like, well, probably, but until we have the pathology, we can't be sure.
You just
I don't know,
had
some gut feeling. I kind of had it, knew that something wasn't right.
Dr. Nye, 26, to have a gut feeling of breast cancer, I don't feel like we're supposed to have a gut feeling of breast cancer at that young age. So, what percentage of patients that you treat or that you know of are diagnosed that young?
The diagnosis of breast cancer under 30 is pretty rare. Depends on the study you look at, less than 1%, less than 4%, but many young women are ignored or told it's benign or it's a cyst or it's related to your hormones. And so it's really unusual to have that gut feeling and to be persistent until it grows, and usually tends to involve lymph nodes at a young age, just because we don't think about breast cancer in 20-year-olds.
Was that gut feeling there because your grandmother had breast cancer?
I don't know. My family calls me weird. I always told them I had this gut feeling that I was going to have cancer someday. Like, I can't explain that, and it sounds insane to most people. I had a cancer policy at work at 26 years old. Like, most people don't think of that. So I don't know what it is. We just had a strong family history of cancer in general. And so I think being a nurse and just knowing, just having that knowledge, I was like, I can't let this go, because the odds of it being something are slim, but what if it was something? And so that was kind of my mindset. And I was like, let's get this out. I don't want to have this in me. So the spot that actually was going to be removed was benign. There was just cancer around it that hadn't been seen even 6 weeks prior in the ultrasounds and scans that they had done.
Smart woman to get that checked out and ask more questions. Dr. Nye, how would you explain invasive ductal carcinoma to someone with no medical background?
So a cancer cell is just when our normal cell learns how to grow uncontrolled, and so it can grow and grow and grow, and that's what cancer is. In our breast, we have many different types of cells, and the ductal cells are the most common to develop breast cancer, and they're what line those tubes that milk can flow out of. So ductal carcinoma is when one of those ductal cells that lines the tube learns how to grow uncontrolled, and that's cancer.
Dr. Larson, how does a medical oncologist giving chemotherapy coordinate with a surgical oncologist who then does the operation?
Yeah, that's a great question. So every person who has breast cancer needs a team of folks to care for them. Every person would need a medical and surgical oncologist, sometimes, as you mentioned, a radiation oncologist too. And the idea is that Dr. Nye is really a biology expert. She knows the biology of the cancer. She knows the best medicine for a particular biology, so medicine is really based on that biology. Surgeons are really anatomy experts, right? So we need to know the anatomic area of cancer. We need to understand the options for anatomically removing it, but it's that teamwork that gets people the best outcomes. So a little bit different ways we contribute, I think, to people's care, but certainly all part of the team in terms of going for cure.
Josie, you were told you had locally advanced triple-negative breast cancer. What did you understand that to mean at the time?
So my pathology results came through on my chart. I'd woke up from a nap. I actually told everybody, like, please go home, I'm fine. And I woke up from a nap Friday afternoon, and it was like my eyes, there was like a magnet to those words, invasive ductal carcinoma. And I knew, I was like, searching, I was like, surely this is like a control saying like negative or something, and I I was like, no, that's it. And so in that moment, I just knew, like, I have cancer and I have to go find somebody who can help me. That was pretty much my mindset. My family they all came over instantly. My coworkers came over and we laughed. It was the weirdest thing, but we sat there and we laughed and we're like, we're gonna get through this.
I heard it was Jordan making a lot of jokes.
Yes, we thrive on dark humor.
Thrive on dark humor, okay. We like that around here.
To get through it, yeah.
Yes, I think we were driving to town that weekend and we passed the sheriff and Jordan's like, it's okay. You tell him you have cancer and you're distraught. Like, you're fine. It's going to be okay.
I think like, that's a fair excuse.
Yeah, I think that's 1,000% fair excuse.
I think this is a good excuse.
Funny. We use that sometimes more than we should.
Use it, go for it, for sure. Dark humor is good, and you need it, Dr. Nye, when you're explaining to a patient that you have triple negative breast cancer. I mean, how do you explain that to a patient, really so they can understand what they're up against?
I'm a picture person, so I usually draw it out. But a cancer cell, a breast cancer cell specifically, we know to look for 3 different what we call receptors. And if you're in my clinic, I describe it as arms on a cancer cell, like hungry, hungry hippo, binding up what it needs to eat. And so the estrogen receptor and the progesterone receptor bind hormones, and that's what helps the cancer cell grow and drives the growth. The HER2 receptor that we look for is a tricky one that can just bind to itself and make the cell grow. But when all of these are missing, that means we have a really smart cancer cell that knows how to grow without being fed by those different things that we have drugs to turn them off. So that means we have to use things like chemotherapy and immunotherapy to target those cancer cells.
And Jordan, you were extremely lucky, doctors say, because your tumor was 4 millimeters in size, about the size of a popcorn kernel, I understand. It was already in your lymph nodes. You're younger, of course, than the recommended age to get a mammogram. I take it you had never had a mammogram before.
I mean, I'm, 10 years from, I was 26 at diagnosis, so what's recommended, 35 or 40? Yeah, 40. So I wouldn't have made it to what was supposed to be my first mammogram without Josie's diagnosis.
Without her diagnosis leading to the family history component to all of this. Dr. Larson, how important is the family history?
Yeah, I think family history is really critical, honestly. It's important for all of us to understand that family history isn't deterministic for what happens, right? So just because a sibling or a relative has something does not determine that we will have it. But that family history and speaking to your doctor about it, that's really how we can have options to keep people safe, right? So we know in medicine some of the red flags where we might need to look into things further, like the genetic testing, different screening approaches, things like that. Dr. Nye does a lot of great work even for patients who are not genetic positive to try to work on their risk of breast cancer and keep track of them. So that family history really helps us as physicians to understand what a person needs to tailor the screening and the care to them and really try to personalize the best outcomes for every person. So
I have a question. So she's diagnosed at a young age, just like her sister, Josie. She learned she has the BRCA gene. I'm curious kind of what that was like, and what her surveillance would have been like over the years, assuming that she wasn't just a few months later diagnosed. Is that pretty typical? I mean, is it
No, this is not typical.
That's what I'm saying, is that, was it because she has a sister who was diagnosed young, or?
It was because of the BRCA1 mutation, the BRCA mutation. We usually start screening at 25.
Okay.
And with her sister's history, we would actually consider starting someone even younger than 25. But we went ahead and started her screening, and I'm just proud that she got it because I've had young women who are like, no, I'm getting married. We'll do that right after. And there wasn't a big mass. There wasn't a big tumor. And so screening was critical.
So
important.
She could have held off the family history component, the genetic screening component. Is that what you're saying?
Both of her age and the BRCA1 mutation were critical to having Jordan show up to get the screening.
Everything worked out perfectly here.
Yes.
So explain the surgical process on why you operate on the breast and the lymph nodes when you're doing breast cancer operations.
Yeah, sure. So our goal in doing the breast portion of the operation really is to remove the primary tumor site. We know that cancer can spread. Cancer can spread through the blood. Cancer can spread through the lymphatic system. So for most patients, the first spot outside the breast where we would see an area of cancer if it was looking to go outside the breast is in the lymph nodes. And so when we do surgery, we want to both get rid of the area of cancer, the primary spot in the breast, and we want to assess to see if the cancer is misbehaving and starting to go to those lymph nodes. That impacts a lot of things in terms of keeping people safe in the future, including what's done from a medical and radiation standpoint.
Be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. So you two basically do everything together. Explain kind of the timeline from diagnosis to treatment. What was different and what was the same?
I had my mastectomy first, and well, actually, we both did IVF. We both did egg retrievals. And then I went into my mastectomy the same day as my egg retrieval, actually. And then I had chemo following that, and then some revisions and surgeries during that time frame and afterwards, which is kind of backwards from Jordan's.
And the reason why she had her mastectomy first is because it was not advanced to any other areas. It was local to her breast. And mine, like she said, was a little bit backwards because mine had already spread to armpit lymph node, and so the plan of treatment was to kill the cancer first and then remove the breast. So a little bit backwards, but
we're still going to end with the same results.
Right.
Yes, exactly. Interesting.
Yes. Yep.
And why is that? I mean, again, it's not one size fits all, right? I mean, everybody is looked at and exactly the same end result, but two different paths.
Yes, we really personalize breast cancer care. It depends on the size, the lymph nodes, the markers, and treatment has advanced that in some situations it's helpful to give the chemo and immunotherapy first and see the response, because then I can tailor any treatments we need after surgery based on that response in the breast.
I want to talk about family planning. You brought that up. Jordan, you and your husband did IVF.
Yes.
Also, because you mentioned you did it, Josie. You have 6 embryos. Tell us about those embryos. You told me some information about that. I think that's interesting. I want to ask the docs about that.
Yeah. I mean, going into this, we knew that we were told, both of us, that IVF would be a good plan, just in case, our bodies did not return to normal after chemo. So we both did egg retrieval, and we went ahead and created embryos, like you said, in which we got 6, and we did go ahead and go through with genetic testing for the BRCA gene to try to stop that. So we tested all of them. 3 are BRCA positive, 3 are BRCA negative, but we plan to use science to help us try to end this horrible gene. So for family planning, we will use, the negative embryos for implantation to have children. So that's our plan in the future.
I just didn't know if people knew that you could, genetic test even.
We didn't know that.
Yeah, I didn't know.
It's amazing what science can do for you.
It's called pre-implantation genetic testing, and it is available now. And so a lot of young women are afraid to have children because they've gone through breast cancer at a young age and they don't want to see their offspring do that. And for those women, this is a great opportunity to think about pre-implantation genetic testing.
Josie, what are your plans? And when's your plan down the aisle?
April. April is our date. We will also do the same. We will do IVF. I just did an egg retrieval prior to my chemo, but plan to do another round of IVF and egg retrieval and embryo creation in December or January, one of the two. So coming up.
Well, I want to get to some questions from our viewers this morning. And Joe Ellen and Marcia both saying best explanation of triple negative I've ever seen. Saying I've never heard triple negative breast cancer described as a smart cancer that knows how to grow without being fed. That's such a great explanation. So thank you for laying that out for our viewers and listeners. Jeremy asks, why are the ducts such a common place for cancer to develop?
They're a common cell in the breast tissue, and some that change over a woman's lifetime, especially as we go from puberty to breastfeeding. There's a lot of change in a woman's breast growth that we feel every month with our cycles, and during that time cells are turning over.
Julie wants to know, can the cancer come back in other places in the body even after a double mastectomy?
Yes. So that is my job, is to make sure that cancer doesn't come back anywhere else in the body. I always tell my patients, your surgeon will make sure that they do the best surgery possible to get rid of the cancer in the breast, but all this chemotherapy and all this immunotherapy is to get rid of cells that could have escaped the breast so they don't show up later as metastatic cancer.
Jeff wants to ask Dr. Larson, do you recommend a double mastectomy for anyone who tests positive for the BRCA gene?
Sure, that's a great question. So patients who are BRCA positive who do not have a cancer diagnosis would usually be eligible to do what's called risk-reducing mastectomy. So that's a bilateral mastectomy, which helps to lower a woman's risk of cancer. It can lower it as low as around 5% in her lifetime, so a significant risk reduction. For women who have a cancer and have one of those genes, they are at elevated risk for a second cancer in their lifetime. So some women do choose to do a bilateral mastectomy as part of risk reduction. Some women choose to be followed closer with increased screening. So that decision is a little bit shared decision making, but certainly the bilateral mastectomy helps to lower the risk of a second primary cancer.
Jordan, Josie, thank you so much for sharing your story today. We're so glad to have you both with us. Jordan, I just want to start with you. What do you want the big takeaway for those watching and listening to be?
I would say just some things for people to know is that one important thing we both kind of realize is that, you know, people think that when you ring that bell, you're done, that you're done for the rest of your life with it, but you're not. You know, I rang the bell the other day, but I've got a surgery ahead and radiation and several months of immunotherapy to follow well into next year. So still lots of treatment left, and even when you are done with treatment, you still have to think about it every day, and you have, you know, scans and blood work, and we have more to think about with our children and other risk-reducing surgeries because we have the BRCA gene. So I want to be positive about this. You know, when I say we're not done with it, but we learn how to live with it and do happy things and get to live in. That's why, you know, we didn't delay the wedding. We just wanted to keep going and doing fun things in life because life doesn't stop. You know, you have to keep going. So,
such a great message. Yep. Josie?
I've said many times in the last month, with it being Breast Cancer Awareness Month, and constant reminders and people asking and, you know, saying you're so brave, and that's true. But life doesn't stop at diagnosis. So while it might seem brave, it's us living our life still. We have weddings and families and, you know, such happy times in our lives. And I think sometimes, like, we would go to appointments and they'd be like, are you guys really okay? You know, because we're doing all of these things still and enjoying life. And I think that that's important to know as someone going through any type of cancer. You know, we're still humans, we're still us. The diagnosis doesn't take us away.
There's hard days, you know, behind the scenes that there's plenty of tears and anger and, you know, asking why. But for the most part, we've done a pretty good job at moving along and keep going.
Just keep going. You can do it.
You ladies are so, you just have such a great spirit. To be continued. Yes. Because we want to keep following your story because you got lots of life to live and lots of babies coming and lots of fun stories to share. So it's just so great to have you. And what a great way to wrap up Breast Cancer Awareness Month. Dr. Nye, what's the big takeaway from this story?
First, these are some of the most inspirational women I've ever met. Grace is one of my favorite words, and they truly just embrace that. So I just want everyone to know how amazing and stoic you ladies are. I don't think I ever saw Jordan without Josie there, and that is so helpful to someone going through cancer treatment, to have a person there, both for the patient but for the care team. I mean, we know that if Jordan's having a problem, Josie's going to call us. So we're not really. Yes, that is typically how it went. So just having a person, be that person for somebody, and knowledge is power. If Josie didn't get tested or say, hey, you need to go get checked, I don't know how advanced Jordan's cancer would have been.
Dr. Larson.
You know, I think what both of them shared is the importance of being proactive, right? And a lot of what I hear from you guys is you can't change what happens to you, but you can be proactive about those things, right? So being proactive and speaking up when things seem off, being proactive and getting the testing and doing the screening, not putting it off for a year or two because you got other things to do. I mean, this is really the example of that, right? So people who are proactive cannot always prevent things, but we can catch things early. We can have absolutely the best outcomes, best life and things like that because you're partners with us in doing that, right? I can't get you from your house and make you come in and do the things you have to do. Proactive patients are amazing because you guys are just the people who do well. You're the people that we can really help, honestly.
Ladies, thank you for your story. Docs, thanks for your amazing expertise as always. Thank you for being here.